Rolling.
Renegades.
Hunter and I had this big idea. Mind blowing.
I had to have the people who didn't believe in me.
Between one day and the next, everything changed.
Nurses know how to solve shit.
Renegades. Cheryl Fields, thank you so much for joining me today. I'm sorry, Cheryl Field. You're just so big, there should be your plural. You're so wonderful, you should be plural.
It's great to be here. I can assure you that my husband is quite happy with only one.
Well, for now, I'd be happy with if we could clone you because you have so much knowledge. I've been excited for this conversation for so long. And I remember talking to you about responsible AI when we were doing continuing education credits for one of the Power Up Nursing conferences. And you just started going off. And I'm like, hold on a second. I mean, and I think it was probably like a half-hour conversation. And it just smacked me upside the head because, of course, AI is coming. And of course, all this stuff is being done. And you just shined a huge spotlight on the dangers of it and how nurses are so vulnerable as we move forward into this new age, their licenses and the safety issues. And we're going to get to all that. But I just wanted to say how excited I am to learn more from you. And I'm glad I stopped you that day because it's built up the anticipation a bit. So why don't we just start? I would love for you to either tell us about, introduce yourself in the informal way. Basically, how'd you get here with me? Where are you from? Why'd you get into nursing? What's your career trajectory? You can either do it that way, or what would somebody who really admires you, how would they introduce you? Pick one.
Oh, okay. Well, I'll probably take that more of a traditional route. It's a story, of course, that I've had the privilege of living and telling. And I did not come into nursing the traditional way. I really thought if you had asked me if I was going to be a nurse, I would have bet you thousands that I would have taken not a traditional female job. I was really a tomboy and headed off into university thinking I would do pre-med and maybe become a chiropractor or go into some kind of healthcare medicine this way. However, honestly, as a learner, I did not do well in large courses. And so I found out in my freshman year that I was not learning well with 600 people in my chemistry class. And there were other students on my freshman hall who were in nursing programs and introduced me to the idea that I might transfer into the School of Nursing. And once I let my adult self, who was no longer in high school, kind of caring about what everyone thought, once I really let that sink in, it's just the best career ever. And it's such a great role. You can do anything with nursing. I encourage so many people to go into nursing because the possibilities truly are endless beyond the bedside. I think we all want our time at the bedside and need that for solidification of assessment skills and confidence building. But I was a bit of a misfit nurse right from the beginning. I questioned policies. I wanted to understand the why. I really liked the business function. I wanted to figure out how to get paid and how to get paid more if we were entitled to it. And what would I document to make sure that we were in compliance? Right away, I wasn't thinking about nursing the way that some of my fellow nurses think about. And so it did set me on a different, career path. I had parents who were entrepreneurs. And so I definitely had an entrepreneurial spirit. And after, 15 or 16 years in, I did my time in acute care and went into skilled nursing, into the subacute space. I found my way into technology. And now it's been 25 years in clinical informatics, where it is absolutely essential that a nurse who understands the clinical workflow of where these tools are going to show up has to be a part of building the tools, or you end up with things that don't work. And so I feel honored to have been, kind of meandering and winding my way through a variety of a couple of startups and larger companies that have afforded me an opportunity to be present with, oh my gosh, I mean, such smart, PhD level scientists who they know how to do all the pattern recognition, the algorithmic work, but they cannot do it without the input of clinicians. And so when we talk about, and this is what you and I were talking about, right? That day, I was like saying, oh no, we shouldn't be afraid of artificial intelligence, but we absolutely have to be involved. If nurses are not part of the work, the model, the testing, the development, the design, the thinking about even what we call it, what do we label it? What does this output become? What does it mean to the nurse in the workflow? It's not going to fit when you plug those two things together. Nurses are going to be like, wait, what do I do with this thing? And how do we do that in a way that, we get the best of the technology and we can enhance the care decision making? We can support that. We'll never take the place of it, just support it. And that's where the promise, the opportunities, I think, lie with this technology in a clinical setting.
Oh my gosh, you just hit the ground running with so much that resonates with me. First of all, my mom used to joke that she had 4 sons and I was the only one who grew boobs. Total tomboy. I became a nurse because my mom told me to. I became a nurse because I still was in that high school mode and cared what people, especially I wanted my parents to like me. And the other thing, I just loved how you lit up when you said informatics. And it's funny because informatics and nursing has always been such like an enigma to me. Like, what is that? What does somebody do? So I want to stick a pin for a second into like the emerging technologies of AI and all of the potential and pitfalls of that. And can you just give us a little background about what is for nurses like me who aren't really familiar with the definition and the role of nursing informatics? Like, what is that?
Well, it's nursing on steroids. Like a nurse goes into a room and provides care to one human with one set of interventions and one set of outcomes. And nursing informatics is taking all of those experiences amongst all of the nurses, all of the people in all of the rooms with all of the interventions and all of the outcomes, and make sense of it for an organization. So when you want to understand a widespread pattern in your organization, all math, all numbers, all those graphs, they're a whole bunch of people rolled up into one column. And that's what nurse informatics is about, is helping to visualize and understand business trends that are really heavily rooted in clinical. And of course, we know the connection between clinical, quality, cost. That's all business, right? That's the link to, is this a healthy organization or not? And how do you even visualize that data, interpret the data? How do you link to it? What's the source? That's what a clinical informaticist helps an organization to do.
Oh my gosh, informatics. There's so much I'm running out of pins that I'm sticking in. So you did your cut your teeth at the bedside and then went into the technology kind of sector of nursing. How did that start out? Like what was that? I hate the word journey. It's so cliche, but what was that journey like?
Yeah. Well, and honestly, Karen, these opportunities they're not so hard to imagine because it's really someone automating how you've been behaving. So I am a systems person.
Mm-hmm.
I came into that skilled nursing space as a clinical director with some reimbursement responsibilities, like how are we going to get paid? What will we get paid? And it was my responsibility to make sure that the medical record matched the bill, that the MDS assessment matched the medical record. So I had a lot of manual processes that I was running around crazy, trying to get all my stuff checked to ensure that we could bill and be in compliance. So imagine meeting someone at a conference who says, well, we can automate the way you think. I remember
That
getting
would freak me out.
like, what? You can automate that. And so I took this leap of faith. I really did. I met what became my future boss. I met him at the podium. We co-presented at a seminar. I was talking about restorative nursing, and he was, the speaker before or after, and he was talking about, accuracy of the MDS assessment and how it translates over to a care plan and to payment and to quality. And I was just like, wow, we need to work closer together, because I'm doing so much of this manually, and you're working for a technology company that wants to automate those checks around what people checked on the MDS to make sure that in and of itself, that data fit together. If you said on page 3, they're in a coma, you shouldn't say on page 9, they took a walk. We know as nurses, comatose patients aren't walking. But the reality was, when you had an interdisciplinary team completing an assessment that was going to electronically be submitted to the government for payment and quality and care planning, you had to make sure that you had agreement between your coding that it did not make sense what you had checked off. So again, I was doing this manually from a clinical reimbursement perspective.
What position were you in that you were doing that manually? Were you like I was
a clinical director of a subacute unit.
Okay.
Yeah. And I oversaw the whole Medicare program. So, I was responsible for anybody who was skilled in the building that we were billing to Medicare, that I knew what their skill was. We were documenting it effectively every day, in order to defend that claim. And then before we sent the bill, I was verifying that we coded the assessment properly, and we, submitted compliant bills. That's the job.
Yeah. And this guy told you how to automate everything you were doing manually.
Was suggesting that he would automate the way I was thinking, because I had, these manual checks. And that's, again, the beauty of technology, right? We can give time back to a nurse if we can automate some of the way we gather data, the way we present that data for clinical decision making. If we can speed that up, then nurses come into that workflow, and they're actually served the information they need in a way that's visually easy to interpret, meaningful to a nurse, and speeds the decision that nurse takes for the next action that they need to do. How much time do we spend just looking for the blood pressure trend? Oh my gosh, what was it last week? What was it yesterday? What has it been? But if we can use technology to bring it, we can actually interpret that. We can say blood pressure is increasing, temperature is decreasing. We can interpret a trend and serve that to a clinician who's then going to be like, I need to go monitor that. I'm going to go check it more frequently, or today, or right now. I'm referring to an in-house doc. They can get more quickly into that next action step that they need to take to mitigate risk factors, to manage the outcomes of care. And so again, my first sort of journey was moving from a clinical reimbursement space into a small startup that wanted to automate the way that data could be checked with software, and giving that intelligence to, again, a nurse who's an MDS coordinator, whose job it is to get that assessment coded correctly. Again, super important, right? The patient's plan of care is going to be driven off of what's coded on that assessment. Let's get that plan right. Let's get the bill right. Let's get the quality measurement right. So let's get that data right. That's really the foundational data element in all of skilled nursing. It still is today, almost 5 years later, since I've come into that space.
Yeah, I can see how it really expedites decision making, so you can ensure that the facility gets reimbursed. So the nurse isn't delivering kind of care that's not covered, but also it expedites the patient care, because the nurse isn't waiting on either doing something that the facility is not going to get reimbursed for, or making the patient wait on a decision to be made whether they can or cannot give this medication, do this treatment. So it's kind of a win-win. And without it, what do we do without it? Well, I
Mhm.
guess we went around with manual
Yeah.
check boxes.
And when you start to run a facility as a director of nurses, I have two concepts. I have competency and I have capacity, right? So we're competent in providing IV therapies, but we might have capacity limits. So as a DON, I need to know how many lines do I have running today? How many people on, antibiotics or blood transfusions or O2 and suction? And what is my staffing? Because at some point when you're making an admission decision, and I think this is very true, skilled nursing facilities have really grown, in their competencies. And there's so much acuity that they're managing in these facilities, but they may have capacity limits. So when there's an admission on the table, the DON has to be able to say, okay, well, we're able to provide this type of care, but are we too full? Do we have 10, 12, 15 vents running? We know we can't take more than that. We know we don't have, staffing, overnights, et cetera. So these kinds of data aggregations, right? Visualizations helps a director to know I have competency, yes, but am I at capacity? And this is an everyday thing, right? I got to make an admission decision. Simple things like that can be made much quicker, where I'm not manually going around to unit managers or trying to, from my memory or from my board, count how many of those do we have? Can I do one more? Right. And that's the decision a human has to make, just something as everyday as, can you take this admission?
It's so funny. Like, as you're speaking, I just had this insight that you and I are both in the business of returning nurses' precious time back to them. Me in the form of education, you in the form of what did you say? Compliance and capacity. All right. Competency and capacity. I just love that. And I love how I've never engaged and spoke with somebody who there's just something behind you speaking about it. There's like a childlike excitement, and we're talking technology, like all this stuff that makes my brain squirrely, because I have a very healthy dose of right brain. But there's something creative about it for you. I mean, there's something really creative about it for you, something that excites you. Can you speak a little bit about it? Were you always like that since you were a kid, that like these like numbers? It's like the 10,000 foot view creativity of what's going out, and I'm just kind of talking out of my, what is it that made everything different from one day to the next for you when you saw that this was going to be your career path trajectory? What excites you so much about it?
Well, I'll be honest with you and say that I'll go back to that chemistry class. Like there were ways that I was being taught traditionally that I was struggling to learn. And so I had to find a way to take what was really complex and make it simple, because I had to understand it. And I think when you get into technology, so I became a systems person. I needed to
for yourself first.
I needed to understand what was going on. And then I could simplify it. Like, oh, okay, well, let's just, I still say to my children, like I would tell them these stories about your trash in your house. Now, if everyone listening just thinks for a second, think about the trash system that you have in your home. There's little cans in rooms. There's probably a big one in your kitchen. There's probably a barrel in your garage. And if you have curbside pickup, right, you take it out maybe once a week to the curb, or some rural parts of the country, you have to go to a dump or a transfer station and bring your trash in. But when you think about the system, what happens if a part of it backs up? What happens on a holiday when they don't take your trash? And in New York City, like they have to take this out every morning. Like the trash is,
or if you forget
enormous,
it's garbage
right?
day, Oh my
Well,
gosh.
this is like congestive heart failure, right? There is a system along the way where little pieces of trash get picked up and go to bigger trash buckets and bigger trash. But when you get to the heart, if you are backed up and fluid is now backing up into the lungs, that means trash is backing into the house. It's not in the kitchen, it's overflowing onto the floor. God, this is CHF. This is fluid in the lungs. This is how I was able to make the body systems make sense to me in the real world. And then I could understand the pathophysiology when they fail. And because I learned that I could make up silly little stories like this to myself in college, and then I went on to tutor other nursing students because I was broke and I needed money. So I was tutoring, anatomy and physiology as a sophomore and a junior and a senior in nursing school. I found that I just loved teaching using these simple stories,
Metaphor.
concepts that were really, really hard to get. And whether it's I think it's a gift. I just think it's a gift. This is how I was wired. But it translates so nicely into technology and an integration with nurses who might be a little technology averse or concerned. What's going on behind there? And I'm like, listen, this isn't the Wizard of Oz. We're pushing back the curtain. I'm going to explain to you in a simple way how how machine learning really works, because it works just like people. It works just like Florence Nightingale. It is pattern recognition.
Really, it's like the universe is just a mathematical equation.
That's it.
Yeah.
The universe is just math.
Yeah.
It's just math. And when you can take something complex and make it simple, then you can teach it. That's where I get my absolute buzz. I just love that.
Oh, you and I we're like sisters from another mister. I mean, that is me too. And when I look at an atom and I look at a cell and I look at a house and I look at a community and I look at a state and a country and a globe and a solar system, like it's all the same. It's like the same operating system. And I love how you brought it from the trash system in the house to congestive heart failure. I mean, that is absolutely brilliant and so true. I can see how teaching like that with those kinds of metaphors would make you a great teacher. And it is a gift because it is a good it's the perfect integration of left and right brain. Like you understand these concepts logically, mathematically, scientifically, intellectually, but then you also bring the creativity of metaphor. So let's see how you explain this whole responsible AI thing. Now just bridge the gap between where you were in informatics and becoming a systems person to where you are today. And then we'll move on with what's going on in AI and nursing.
Yeah. Well, so, you go from this, my first introduction into technology, which was automating, just making sure that this data, that the MDS data was accurate, because it was foundational to all of the other reporting that the nursing home industry relied on. So
wait,
I went
for all those who don't know, what do you mean by MDS?
Oh, sorry. So in the skilled nursing space, for anyone who's never worked in a skilled nursing environment, this will immediately give you a tremendous amount of respect for that care practice. Every 92 days for every human sleeping in a nursing home, we basically do a form that's almost as long as doing your taxes in the United States. 520, 530 questions get answered. And they get answered as of a certain period of time, just like our taxes are 1 calendar year, and you have to answer all those questions based on that time and the data. We have to answer these questions about the humans.
How many?
Maybe, almost, again, 525, 530 questions. I don't know how many questions there are today. It keeps getting more and more. And the questions have a time period. So, Karen, imagine if I said, how many times in the last week did I take my vitamin, take an antibiotic, take an antipsychotic, take a certain type of drug, use the bathroom? Were you wet? Were you dry? Did you need help with bathing, dressing, turning? All the data that would build a plan of care. It's enormous numbers of questions, and they're time boxed. Count in the last 7 days, how many times did this stuff happen? It's crazy. It's crazy. So we call this, and I laugh, we call this the minimum data set. This is the least amount of data the government thinks they need to collect on all of these humans every 92 days in order to assure good quality, proper payment, and a care plan is built. So I had the opportunity to stay in that role and grow into visualizing population quality metrics, population payment. I was really, customers were calling and saying, hey, you have all our data. Can you tell me how many of these I have? Can you help me with this rule? Can you help me get ready for survey? So we started thinking, well, how could we repurpose the information and show how could we help answer these very practical questions that directors of nurses or administrators of nursing homes needed to answer and do it more efficiently than what we knew they were doing, which was printing out very long reports from the Centers for Medicare and Medicaid Services, highlighting human beings' names, going to the chart to check stuff. Could we help make that faster and give time back for direct care? So in those worlds, in that conversation, constantly at trade shows and discussing with customers, and regulations help to push what we will build in technology, came this notion that there would be a penalty for too many returns to hospital for both hospitals and nursing homes. You remember the government said, hey, by the way, healthcare providers, you're sending too many people back.
Yeah, we're not. Yeah, they weren't going to reimburse for readmissions. That was when I was working in an ER.
Well, and it's interesting when you kind of come away with they're not going to reimburse. They're going to penalize you on a future claim. You get paid for the work you do. We are still in a fee-for-service world. Someone comes in, of course you're going to take care of them. And yes, the hospital gets paid. Yes, the nursing home gets paid. However, again, clinical informatics, at the end of a year, when we look at all those people, all those individuals get aggregated, and we look at who was really at risk maybe for going back to the hospital and who did go back. The government penalizes you if you just, frankly, you send back too many people based on risk adjustment, based on their clinical stuff. And so I had an opportunity to be involved with, again, data scientists who were trying to get ahead of this. So we were trying to predict, well, who is most likely to go back? If I'm running a nursing home and my hospital doesn't want these guys to come back, can I predict who's likely to go back? And can I get ahead of it? Can I round more frequently, have the nurse practitioner see them, have the doctor see them? Can we do something different to prevent them from going back to the hospital unnecessarily, right? I still remind people that the skilled nursing home is a place where you can receive care. And if we have a known diagnosis for you and an anticipated treatment plan, we can make that decision of admission based on competency and capacity, right? Hey. However, if your condition changes while you're living with us in this nursing home, it is my responsibility. If I do not know, what is this diagnosis? What's the anticipated treatment plan? Do we have competency and capacity? If I can't answer those questions, and it is my responsibility to send you to a hospital setting with all those diagnostic tools where they can answer the question, is this a new diagnosis? What is it? What's the anticipated treatment plan? Oh, okay. Now that we understand this, can I send them to the nursing home? So there's some things we can handle, right? A bladder infection. Nursing homes can take care of bladder infections. But if you have a full-on stroke and you need to have a bleed clipped because you're bleeding inside your brain, we're not keeping you at the nursing home. One, we can't diagnose it. Two, we can't treat it. And the treatment plan requires more intensive recovery for maybe 12 to 24 to 72 hours. Then you can come back. So at times when someone's condition changes, it's very appropriate that they go to a hospital setting. So the government was trying to get at these things that we'll call the unnecessary returns to hospital. And I had an opportunity to work with a team that was going to, hey, let's try to predict that. How do we predict the future? We usually look at historical information, right? We look back in time. We try to find 1,000, 10,000, 100,000. Do we have 1 million of them? Because if we have 1 million, then we can maybe recognize a pattern more accurately than if we only had 2 or 3. So in this case, size of data matters. And when you work for a provider that is receiving a lot of data from the skilled nursing space, it's almost it's a privilege and a responsibility, right?
Yeah.
To leverage that data for good for the population by understanding what's happened in the past with these and what patterns can we see in this massive amounts of data, and can we therefore help predict for the one grandma who comes in, gets all the millions, gets leveraged, and we can look at all those patterns and say to the one, based on comparing you to all these other, and it's just math.
It's just math. And I just, it's kind of a tangent, but hopefully it relates back, just like the garbage system and CHF. But you just made me think. So like, how everybody talks about my phone must be listening to me because we were just talking about a certain kind of dog food. And all of a sudden on my YouTube or Facebook, a commercial popped up for that kind of dog food or whatever. Is that just predictive data collection? Like, is something really listening to me, or is that just like historical data collection? She went to this website, she drove to this place because, my Find My iPhone or whatever is on, and it can see like all of those little bits of all of those little categories of data. And yeah, she's going to buy dog food. like, is it the same thing, or are people really listening to us?
Well, I think there's a lot of great questions there. And I would say that data that gets shared, and I don't know how many of those platforms, so I don't know what data sharing rights. Let's be honest, when you download an app, you double click on the side and you say accept and you move on, but hardly any of us read the privacy agreement. So I don't know how much of your data they're sharing, but here's what I do know. Within one device, right? On your phone, you have maps, and if you go every Wednesday night to get dog food, you're going to get in the car tonight and it's going to say, are we going to town for dog food? And that's predictive based on a pattern. And I know when my kids were playing soccer, and Wednesday night was, Wednesday night they had soccer in another town, my map would come up and show me that town on a Wednesday night. Even if the season ended, it still thought I was going to go there because for the previous 6 weeks on Wednesday night, I did. That's pattern recognition and a prediction, but it's kind of limited in its data, right? You got in the car and it's Wednesday. There could be more, in humans, there's more finesse to the predictability. There's more data that we can use. It's not just the diagnoses that you have, but also your age, your medications, your other comorbidities. Like in the first work that I was doing, when we were trying to predict return to hospital, we would have looked at somebody having congestive heart failure, and we would use a type of analysis they call regression analysis. And again, I didn't know what this stuff was. I was just smart enough to ask questions like, what the heck? How are you guys doing this? I don't understand. And they're like, okay, well, every time, so you nurses got together, we asked you some questions. We said, hey, what data do you think about if you were going to predict someone was going to go to the hospital? What kind of patient do you think would go back? And then I said, oh, well, those congestive heart failure patients, they're kind of hard to take care of. They might go back. Well, why? Well, they could gain weight really quickly, and then all that fluid is in the lungs and they're not breathing, and they show up to physical therapy really short of breath and their oxygen saturation is low. That's what it looks like. But the underlying cause is, kind of fluid overload. And so they would take those conversations and they would find that data on this thing I was saying, on an MDS assessment. Well, we have things like heart rate, oxygen saturation, fatigue. These are things that we could find in the data. And they would go and look for patterns, and they would see, well, which congestive heart failure patients actually went to the hospital and which ones didn't. And what were those kinds of things? And maybe they would, and then for each time you saw that condition, they gave it a fixed number of points. Every time we see CHF, give them 8 points. That's it. With machine learning, with the different approaches that we can do today with technology, it's not a hard, fast rule that everyone with congestive heart failure will have 8 points in a risk algorithm. In fact, it looks at all hundreds of other features, and then it can adjust that score, because congestive heart failure isn't always a direct, not everyone with CHF goes back. And that's really where we can fine tune and improve the technology. So you and I both know as nurses that just having congestive heart failure doesn't mean I should call you an ambulance. Right. However, when 8 or 10 other sequelae show up, I'm thinking, there's something going on here that I'm not sure I know exactly what's going on. I might need some diagnostic input in order to figure out the treatment plan. I think we need to have this person looked at in the emergency room, because here in the skilled nursing, I can't get either the physician or the quality of the x-ray or the quality of the CAT scan done quick enough, and their condition's degrading. So off they're going to go, right? And we make those decisions. So imagine having some input that could help predict the likelihood of that a week in advance. Now, as nurses, we are tuned in. We've got our good stethoscopes on. We're listening to those lung sounds, and we're hearing that fluid days before it shows up as shortness of breath in physical therapy and a diminished O2 sat. Because oftentimes that's how far it would get before we picked up on it. Did you see the difference?
Yeah. So basically, but when you say our good stethoscopes, you're meaning powered by, as a metaphor, powered by.
No, I actually mean make sure you have a decent stethoscope with double lumen. And, honestly, one time in my career when I was doing, root cause analysis we had, some poor clinical outcomes. And I was like, why couldn't the nurse hear that there was, congestion in those lungs? And I'm like, and when part of the analysis showed that we had $3 stethoscopes, you couldn't hear crap through them. Yeah. Like, you got to have good stethoscopes on your unit. And at the time they were provided, we provided stethoscopes for everybody, but they really weren't. And then there were, then those, the nurse who had her own, I always had my own and used my own, but not every nurse carried their own. And so I think, anyway, it was one of our findings.
Yeah, no, I always prided myself on being able to hear all kinds of crazy heart tones that nobody else could hear. So that was like one of my favorite things, like, the different tensions and the different, areas and where you could hear this and that and analyze them. I was kind of a geek about that. I loved that. So what is the now application of what you were doing with this machine learning and systems and the evolution, and now the application of, we'll just talk about the evolution and the emerging AI, how that's being applied. Start however you want, because I want to get into this.
Yeah. Well, you don't have to look very far, right, to hear the word AI. It seems like everyone's talking to Chat GPT, and if you say the wrong thing, your watch will answer you or your phone will start to anticipate. So I think that the reality is it's not something that just showed up last year or the year before. We've had this technology. If you really look historically, the technology existed back in the 1950s and the 1960s.
And certainly with what you were talking about, the data aggregation to make predictions. I mean, you could see the seeds of it when you first started in doing what you're doing.
But when you look to the healthcare sector, Karen, we didn't have access to the data, right? We were writing on paper.
Yeah.
Paper. And the hospital became digital before skilled nursing. And many of your dentists are still on paper. Right? When you think about it, when you go to your dentist, does he still take a physical file out of an area and start looking at, you see where your cavity was 3 visits ago? And, some of that's paper. What does that mean? It means the data is not accessible to scientists. We can't learn from the aggregate if we haven't digitized the information. So why we're here today is because 1980, 1990, 2000, we as an industry took on the pain of digitizing workflows. And I still think it's a pain. I think, when I talk to nurses that work, in the hospital systems, and they'll still say, oh my gosh, I hate this. I don't love my EHR. And, having an electronic health record is essential. And some standard data elements are essential for us to harvest that data, right? We can't pick what hasn't grown. Again, I talk about data science, and data scientists, they're harvesters. They harvest data, they package it up, and it's everywhere. We need pickers. If you have a young person that's thinking about what to go to college for, and they're not sure, push them into data scientists. They can be in any industry that they find interesting and exciting, because we harvest retail data, we harvest cosmetology data, we harvest healthcare data, we harvest business data. So become a data scientist and go work anywhere you want. But you're going to be very valuable because you're the one who can bring in that information and then, help to the teams to analyze. So because we had the technology, then we digitized, we had a source of information. And, we've definitely had improvements in processing speed, processing time. Now it's they've all come together. So we can apply algorithms on huge volumes of data rapidly. And because again, it has to work. It has to work in real time. We have cars that drive themselves. How do they do that? They are making a decision in the car. We don't have time to send a signal to the cloud, run a prediction, get the prediction outcome, send it back to the car and say, yeah, you should brake now. You've already hit somebody. Yeah. And those are fractions of seconds, right? Which means we have to make the prediction and run that in the car itself, which is why manufacturers like NVIDIA, who makes chips that can process large amounts of information quickly on a teeny tiny little device that can be installed in your car, in your phone, or in any device. That's why they're doing so well, because they were the first guy. I think they were the first in that space. They had these gaming chips people were using to play games on that had so much room and so powerful that we could run a machine learning algorithm or a large language model or a small language model on that chip in the car where it needs to be, not in some data center, in the east or west coast of the country. Those seconds matter. And so the place where we are today, which is a very exciting place, and for healthcare, of course, I think there's more risk, right? I mean, although trust me, a car driving is frightening, but there's a human at the wheel. There's still a person sitting there to say, I'm going to put the brake on, right? Now I think they have these cars that drive themselves around, and that scares the bejeebers out of me.
Oh yeah, you see them in LA all the time.
Because I think in that use case, technology is replacing the human. And in healthcare, there is no intention for the technology to replace the human. The technology is there to guide the clinical decision that the human makes. And that's a very important distinction. It's a distinction that you hear the American Nurse Association, the American Medical Association, not just in this country, but internationally. That's the whole concept of we should do this, but it should be done responsibly. We're not looking to replace the human.
Do you think that nurses could ever be replaced by AI? You know, there's all the talk about, you know, whole industries going away and whole professions going away. And I, as of yet, can't figure out how you'd ever replace a nurse, even if you have like some kind of silicone cyborg that had a body and arms and stuff like that. I don't know.
Well, some of those robots already exist, and they exist with conversation. They exist with storytelling. They'll sing songs. They can help to alert and orient a patient. If the patient says, where am I?
Mm-hmm.
What day is today? I don't know how much further, that will go. The ability to, well, if you've asked ChatGPT anything and gotten a response, you're like, wow, that's pretty cool. So you could ask it questions, and there could be a language model in that silicone thing that will answer your questions. And what we do know about those kinds of word algorithms, and they are just, I will simplify them with, and it's probably wrong, but I simplify them into things like, when I say Mary, you can kind of know what I'm going to say next around the holidays, right? If I say Mary, Christmas is coming, right? Happy New Year. Those things go together in my sentence, especially when it's December, January, and I'm signing an email. So if I'm a language model, I could kind of figure that out. Hey, this person in this MAC address, which I know is in the United States, in a heavily Christian part of the world, when they say Mary, they're going to say Christmas. And probably
more likely than Queen of Scots.
Say it again.
More likely than Mary, Queen of Scots.
Correct. Yeah. Correct. And so that's why you see when you're typing suggestions that are oftentimes wrong.
Yeah.
But those are only based on patterns. Look, if you look at language patterns and you look at dialects and the way that nurses write, although again, we don't write in full sentences, and we use a whole lot of shorthand.
Yeah.
That's very challenging when we want to try to train a language model. But that I do think that the technology will ease some of the demands that are placed on nurses in the repetitive,
in
the administrative, in the data gathering, in the visualization, making sense of, and even helping in some responses. Like, again, I think it's wonderful when you see these little robots at the front entrance that can welcome a guest or a visitor and help them to fill out the visitor pass and get their name and ask them the COVID questions and say, oh, you're visiting with Cheryl. She's down the hall and to the left. Like, those are wonderful uses for technology, but that's not replacing a nurse.
No. And I would love to hear from you, because I know there's so many exciting things. I haven't been in a hospital though, since 2004. I mean, I've been in a hospital, but I haven't worked clinically since like 2014. And I know that there's so much happening. And, I do a lot of podcasts and talk to a lot of people about burnout and etc. And my hypothesis, or my experience, is that it's impossible to burnout and purpose and meaning in your work are mutually exclusive. Like, it's hard to get burnt out, but when there's so many redundancies in charting and in patient care and regulatory things that, you just have to check boxes, and it takes you away from your vocation for the reason that you got into nursing for the first place, which was the patient relationship, the nurse-patient relationship.
Yeah.
And we don't have enough time to swim around in that vocation part of nursing. You're just more vulnerable to burning out. And my excitement about the potential of AI technologies, before we get into the pitfalls of them, is, do you see a lot of, just kind of expanding on what you were just talking about, that AI could help to remove or reduce some of those redundancies to bring nurses back to the the vocationary parts of their profession?
I think my answer here might be a little controversial in that I think what I worry about is the business pressures of healthcare, and that if a nurse were to have the support of anything technology based, there would be a perspective that just means that they can do more volume and not actually spend more time with that human, not really listen, not really be present. And so I'm a little worried that operators have this as their intent. We'll invest simply so instead of a ratio of 10 or 12, I can give them 14. And that to me, that would be wrong. That's not the reason to invest in technology. I think we need to invest in technology because the nurse who's caring for 10 or 12, and that's a number that comes from my space, right? In the hospital setting, in an ICU, 1 to 2, if you're in a step down, maybe it's 1 to 4, 1 to 6. I don't know those ratios because I don't know that space like you. My point is that the nurse should be supported in those 6 so that what they can control is their fight or flight response. If nurses are living 12 hours a day in fight or flight with their, sympathetic nervous system, like on hypervigilance, on, because they're so behind and they're rushing to achieve the tasks that are assigned as interventions to the humans they're caring for. And I mean, gosh, what if one little tiny thing doesn't go right, or that patient, patient number 4 who's in the hospital happens to have chest pain, and now you're dealing with another situation that's going to require assessment and intervention. The stress on the nurse to control their sense of schedule, their sense of completeness, is where I think the burnout is coming from. Because instantly, when there's a call out, instead of being 1 to 6, someone says, well, you're going to have to go 1 to 8 tonight. And nurses don't have any control over that.
Well, they do, but they don't.
Leading cause of stress.
Yeah, they do, but they don't exercise it. I mean, I think you only put up with what you think you deserve. And there is a pathology in the personality of nurses that makes them wonderful caregivers. It's the reason that the profession draws us, but it's also the reason that we allow ourselves to be, it's a dark and a light to everything.
Yeah.
And if nurses just said, I know I'm oversimplifying it, but when are we going to start saying no more, and the things that you were talking about, I think that if nurses weren't part of the bed charge and we build just like a doctor or a respiratory therapist or a physical therapist, then it would, I don't know. This is just coming to me. It seems like that would kind of prevent some of those abuses of technology.
Well, that changes the motivation as a hospital administrator, right? Now, as an administrator, you want more nurses, and you want those nurses to have time to give intensive interventions that they can bill for, because you get a piece of that. And that's again kind of a different outcome from when you structurally change the business of healthcare. And I don't have all the right or wrong answers. I know there's reimbursement committees out there that are trying to work at healthcare transformation. What I do know is that if you take your car to the mechanic and he says he needs an hour and a half to change your brakes, and you tell him after 45 minutes, buddy, take it off the lift, I gotta go, you have terrible, terrible outcomes. So when a nurse says, I'm going to go in and do this burn treatment, and it's an hour and a half, nobody should tell that nurse to do it in 45 minutes. You have terrible outcomes. And nurses, and like I said, simple analogy that everyone can understand, because we all take our car to the mechanic for brakes. And, we can't keep asking nurses to do a brake job in less time and expect better outcomes. And you can't do that over and over and over again. That pressure is where I think nurses get into feeling like they're burnt out, because again, neurologically, they're on and they're in fight or flight all day. They're not eating, they're not drinking, they're dehydrated, they're literally not even able to use a bathroom in a 12-hour shift. They might leave, and if they were to wear, a ring, I wear my Ultrahuman ring. And if they were to look at their heart rate variability, it would be terrible after a 12-hour stressful day. Could you imagine a world where a nurse could have a terrible night's sleep? Like, imagine I have a 12-hour shift. It's traumatic. I'm bagging. I'm in the ICU. I've got these patients that are half dying all night long. I get out late. I get home. I'm supposed to come right back. Maybe I have literally 8 hours in between my two shifts. And of those 8 hours, I sleep 3. And my ring tells me you had 1 complete sleep cycle. Like, you're basically, you almost have the cognitive ability of someone who's been drinking. Like, sleep deprivation and DWI are the same. Why are we having that nurse come into work? She's not safe to work. But the system doesn't allow that nurse to say, hey guys, I had a traumatic shift yesterday. My ring says I shouldn't come in. Like, I'm not really good to go back to. I can come in. You know what? I could come up to a floor and do some med surgery stuff, but don't send me back to the ICU. My ring is saying I shouldn't. The data says I'm not okay. Instead, that nurse, if the nurse were to call in, they would be written up. They would get, and that's what leads to burnout, that we don't look at the biological health and well-being of our nurses.
That's really interesting what you're talking about, though, because that would mean to prevent negligence, malpractice, medical error, all that stuff. If you aggregate that data, nurses with these kinds of biorhythms and are
That's
more
right.
likely to make that
kind of absolute life-changing mistake. And you're absolutely right. And that's, those are some of the conversations, again, like we have at Power Up Nursing, which is how can we get the world to pay attention to the fact that their workforce, their nurses' health and wealth, not their wealth. The nurses' health is the hospital's, wealth. Because at the end of the day, it's that nurse, to your point, who is probably, not, maybe they're going to make a mistake that is, causes someone, a negative outcome that hurts the reputation of that care practice. And how wonderful would it be to have an operator who says to their nursing force, we care so much about you. We're going to change our policies and have them be data-driven. Here's a device, wear it. And we know that this kind of sleep cycle or this kind of heart rate, you shouldn't work today on that floor. Maybe come in and cover something or take the whole day, or take another 8 hours, go get some sleep. And I think I think we have to become more fluid in our workforce. And I don't know how that all gets managed at scale, and how we work with unions and laborers. Because at the end of the day, you got to have people in the building. We know that. But if we could stay healthy and we could be well and we felt understood, that speaks so much to burnout prevention. And I think in the
better patient
setting,
outcomes.
Yeah. What I think nurses do is they just move. So if the hospital is too stressful, you move to another setting. Maybe, for me, I liked the skilled nursing space because people stayed for 3 or 4 weeks. Now it's only 2 to 3 weeks, but I liked that pace. I got to know you, and I might have 20 of you, but I got to know you.
Yeah.
I didn't have to remember everything so quick, so fast. That was really hard for me as a nurse. Some people move and go to home care because it's one-on-one, and that can help them with that stress, but it may not be the kind of, nursing that they like or that they love to do.
Oh yeah. Like for me, 2 really critically ill patients, because I got to spend time with the patients when they were conscious, or the families, like I loved recovering hearts, and it was really focused, all of the things that you had to pay attention to, but just everything's right in front of you. Whereas when I would get floated to a med surg floor and I'd have 6 to 8 patients, I was always so scared I was going to kill somebody. I was going to forget something, because even though the acuity of the patient wasn't as high, it's not how my brain worked. And I would feel so burnt out by the end of the shift, just trying to remember so many things for so many different people, even though they weren't acute things.
It's true. I think nurses are constantly, switch tasking, right? Nobody can multitask. I've actually come to believe that our brain, is really going to access one file at a time. You read it, it puts it back away. Like, so we can switch from file to file, task to task. Imagine what's going on in the brain of a nurse who, like you said, has 6 or 8 or 10 or 12 patients. Imagine how much switching happens in the hallway. In this room, maybe humor works. You go in, you can tell a little joke. They like humor. You have to do that awkward or that uncomfortable, that painful dressing change. You get through it and you go out of the room. And in the next room is the angry family, right? And the person has a terminal diagnosis and they're all pissed off about it. And, you have to go in and do a piece of, maybe you're, whatever, you're hanging an IV or something, but they're mad at you. Well, the humor is not going to work in that room. So you have to switch in the hallway, like what's going to work in this room. And that amount of energy that it takes from nurses who are, we are constantly in and out. And, I think the good nurses, the really empathetic, feeling, touching nurses, they literally change it up. They meet you where you're at. They provide care. They figure out what works. But they are so tired. That's draining, that constant changing. So, I hope that technology can help. And just imagine if you could, if you ran a nursing home, and I say this to myself sometimes, wouldn't it be great if you could go in and say to your, I don't know, computer, your electronic health record thing, hey, I'm the DON. What should I be worried about today? You can ask it a question, and it's surveilling in this reality of, concerns. Now, again, none of this is magic. In order to say, hey, what would I be concerned about today from a DON perspective? You'd have to work with lots of DONs. And you'd have to say, what are your top of concerns? And then you'd have to train that model to think like that. And then it is an algorithm. It will do it on its own. It will do more than what you train it. It will learn from feedback. How cool is that we can think about harvesting technology that does reduce the stress and the anxiety in some settings where clinicians could be supported by, smart applications.
Well, how are you on time? Do you have more time?
I do.
You have some space? Because I really want to ask you about what are you most excited about, and what are you most scared or freaked out about the emerging technologies in healthcare, their applications? What are you most excited about? And then after that, I want to get into because you're a great teacher. Obviously, it is a gift, the way you bring in metaphor and everything like that. So I'm so excited when you get the chance to put, information and courses about these emergent technologies on the RNegade platform, so our nurses can benefit from your knowledge, wisdom, and experience. So let's spend the rest of our time kind of digging into that. What are you most excited about? What are you most freaked out about? And what are you loving to teach? What is your teaching passion at the moment that you're going to share with RNegade in the future?
Well, I'm really excited about the need for nurses to be a part of successful and responsible artificial intelligence, and how that's going to have an impact in healthcare and healthcare transformation. What's become clear is that you have to have subject matter expertise in looking at and evaluating and designing models, their effectiveness, their risk tolerance. None of this, when you make a prediction, like, you could be right or you could be wrong. It's true for humans, right? But we want a model that will predict, I don't know, with the same accuracy as a human, more accuracy than a human. Like, what do we think is good? And clinicians have to play a role in that in order to really get technology that's going to make a big difference in care outcomes. So I'm most excited about the fact that I think artificial intelligence is shining a spotlight, and the value of nurses is really being seen. And it's going to grow. That's going to continue to grow. You see organizationally, you see institutions, higher education institutions starting master's programs in artificial intelligence for nurses, right? In the nursing department. So those things really
excellent.
make me excited because again, it puts a spotlight on our value in that healthcare sector, in that healthcare space. I'm not really a person who gets freaked out, but I do think that it'll take time to actually figure out how many models do we need?
Yeah.
What do we need to predict? Like predict and when? And we've been using, we've been using alerting technology in the healthcare space for a long, long time, sounds and beeps and alarms. And, how does that get replaced by advanced technologies? And what's the outcome to the patient? What's the impact to the nurse? I think it's going to take a little longer than, just getting your phone to talk to you and tell you, where the next chocolate ice cream cone, where's ice cream around me? That's a simple question. And let's be honest, if you drive to the ice cream stand and they're closed, it's a pretty low risk, right? You screwed up getting ice cream, but we got to ask questions about, a human and their risks with health outcomes. And so we've got to be more right than wrong. And to figure that out, again, it's exciting because I think the clinician comes centerfold in helping to do the preliminary work that helps to train these models and then see how the models go. Collecting feedback ongoing from the user. Hey, did this prediction help you? Collecting that kind of feedback is part of a responsible application, but it's really exciting because then we can help to have those models, learn more into the future.
Well, when you say responsible AI, what do you mean by responsible, especially in regard to the nursing profession?
Yeah. And so it's a great question because the technology got out faster than our rules, right? Got out faster than Washington. Let's be honest. Everything's faster than Washington.
Right.
But from a regulatory perspective, and again, if you tune into this conversation internationally, countries are trying to figure it out. What are we going to allow or disallow technology providers to do? Can anybody build a predictive model on any data? Can we just, does size matter? Is it okay to build a model on just an itty bit of data? Well, yeah, it does matter. So responsible AI is a set of governing rules to think about your model, its fairness. I'm gonna tell you, every set of data has bias. Well,
yeah.
What are they? Our nursing home data is in the United States, predominantly white, widowed women. Now, if I'm using it to predict on nursing homes, that's no problem. But we could acknowledge that using that data to predict on a Black male may not be as accurate because they're not as much represented in our geriatric population. So every set of data has bias. Understand your bias in your data. We actually need to tell the consumer, here's kind of like, think of it like a nutrition label. Here's our model. Here's what we trained it on. Here's what it can do. Here's where it's good. Here's where it's not good. And as a user, you need to know that so you don't apply the model in the wrong way or in the wrong place. And that's what we mean when we talk about responsible artificial intelligence. And you'll hear the word artificial intelligence. You'll hear augmented intelligence. Again, I mentioned that, like, the American Nurse Association, the American Medical Association, they've just come right out and said, this is not replacing humans. This is augmenting a human's intelligence. And as a clinician, we carry our license. So we will still have that ultimate responsibility of clinical decision making, even if, there's an alarm going off. Like you said, you were saying it's all around you, but you are very focused on the human in front of you. And as the clinician, if there's a disconnect between the alarms going off, saying they're breathing too fast, and you're looking at them and you're counting respirations and respirations are fine, something's not right? Your clinical decision making is still there and needs to be present. And I think that's where I want, clinical leaders asking good questions. And this is something I want to cover when we think about responsible artificial intelligence and what clinicians need to know, what clinical leaders need to know. I want them to ask really good questions, because they're going to show up, they're going to go to work, and the nurse, the hospital administrator or CEO is going to say, hey, we've got a vendor coming in today. They've got AI in this thing. First of all, I want that clinical leader at the table. I want to make sure they're a part of that decision, that discussion. But I want them to have great questions to ask that vendor. Hey, what kind of model would you train it on? What does it do? What does it not do? What are the bias? What is it? Because that's what they're proposing.
Most people don't even know those questions to ask.
Yeah. And those, those come from standards, that are coming out from organizations like the Office of National Coordination, who really, put out some of these standards, and organizations, like mine, we think about that and we organize ourselves and we govern ourselves to be responsible. You don't want, like I said earlier, you don't want to make the wrong prediction. Although models don't predict accurately, humans don't predict accurately. We don't even think about that. We think, as humans, we're actually quite accurate. And the truth is we're not.
No, we're really bad predictors. We're really good in the present, but yeah. When we spoke, months ago, you were talking about responsible AI. And one of the things that really struck me, that kind of blew my mind, because I'd never thought about it before, was what individual clinical nurses need to be aware of as the regulations and the oversight and the responsible AI is coming into, hospitals and facilities that clinical nurses are working in. So what are some things that, while the infrastructure for AI to be introduced, more and more is being built, what are things that they should really be aware of and careful of, for them, their license to be safe, for them to be safe, for the patients to be safe? What are some things that kind of just stick out to you?
Yeah. So I think that as we see these kinds of technologies come into play, first, if you're asked, if your organization has an opportunity to be a part of a beta, lean in and say yes, and ask a lot of questions. Come in with a lot of curiosity and a lot of questions. I think, we talked about how could I support, the nurse, and wouldn't it be great if I could go into the room and, you asked if your phone was listening. Would it be great if a device could be listening and I'm talking out loud saying, okay, I'm checking pupils, I'm checking grip, I'm doing a neuro check. This person just hit their head, and it's capturing that and starting to form my documentation, right? My note of all of that assessment. I think that's a great asset to the nurse. Now, it means that care looks a little differently, and we show up, differently, and our patients have to be okay with this other party, this listening device that's joined the conversation and seems like is a part of our otherwise very private space, our interactive space. So I think nurses need to be asking all of those questions around how will the technology show up in their clinical workflow? What is expected of them? It should, in my opinion, these kinds of technologies, if they're truly augmenting, then they're extra, right? They shouldn't be, I don't know if I want to say it shouldn't be mandatory. I shouldn't be taking, told to make a certain decision because of an algorithm, especially if you don't understand it. So again, I'm saying to nurses, ask the questions. Hey, this thing is beeping at me, or this new thing, someone came in with a new And I'll say, let's put it into two buckets, right? Is it making a prediction, or is it giving you language? Is it summarizing something, or is it listening and telling you something? Those are two different types of models, and you ask different questions based on what it's showing up at. Something that's making a prediction, nurses always ask me this. Well, what kind of data did you use? What did you stick in there to make the prediction? And, a nurse might have, that one thing, that one time you sort of got burnt by something, and you add it to your checklist, right? That one aberrant thing that, the family member that's irate, or when they come into the hospital and the son's a lawyer, you're like, oh, gotta watch this one, right?
Right. Well,
we feel a little differently. But what sometimes as nurses, we add that risk factor into our mind. And you should ask, hey, what did you guys think of when you consider, what data do you think of when you make this prediction for me? And the same thing when it's answering a question. If you're going to ask a question to, and again, we see this kind of technology popping up. You're going to ask a question to a robot about a human. What data's in it? Since when? Since a minute ago? Since yesterday? Can it tell me something that's, kind of a privacy concern? Like, you have to ask all those questions. What are the rules and the parameters? And I think, I really hope that nursing leaders, nurse executives are at those tables when the discussions are happening with the vendors, and they are in fact a part of planning a beta testing and understanding, asking great questions long before it shows up in an in-service training or, up on a unit. And that's what I think is really exciting for nurses.
Yeah. And I've learned that the best question to usually start with is, what would be great? Imagine if, because it seems like the things that we thought were impossible yesterday are like, it's like old news, and it's happening faster and faster. So nurses have to be at the table as these technologies are.
Well, and if you look around, Karen, nurses are the innovators.
Yeah.
So, they're out in Vegas at the health conference. I think you were there. Nurses have been thinking about these problems for a long time.
Yeah.
And, I often ask myself, if software were magic, what would it do? Like, when you remove the parameter of what you think of as possible, and you let the impossible, just sit with that for a minute. The impossible is possible. What would it do? What problem would it solve? I often ask this question when I'm teaching, and I get amazing ideas from nurses who have really lived in these problems. I think it goes back to how our story opened up, that I was an easy transition because I had built a manual system. I was trying to solve problems with a manual audit that was reproducible, pattern-based. I had found a proven success track record. And then someone said, well, we're just going to write that into code and let it run without you. Wow, that was very empowering, cool. Right? Yeah. And so nurses who have been in those problems, who have thought through the systems, who've really figured it out, they are our innovators. They have, and I'm so excited to see what they're going to innovate. And I know that there's ideas, impossibilities that go beyond my brain, that nurses are going to lead in innovation. And that is definitely an exciting factor.
Oh my gosh. It would be my imagine if dream would be to have just like a dev team. Like, all of the crazy ideas I come up with all the time, if somebody could just like make the app. I don't care if it even succeeds, but I have so many ideas that I just want to get out there. And what I love about listening to you, and it's just like yet another evidence for when somebody's really passionate about them. The story arc is usually, this is how it changed my life and made everything different for me. I wanted to give that to everybody else. So you started teaching it to other people's one at a time. And now you're involved in these emergent technology, big, companies that are starting to bring it to the world. So it's always that starts with me, changed me. I want to bring it to other people. And it just keeps getting bigger and bigger. And it's just a beautiful thing. What are you thinking of? I know you teach a lot and I know you speak a lot. So what are the things that are most exciting to you in the last, 2 minutes that we have, say, that you maybe are going to be sharing with the nurses on the RNegade platform? What are you most excited about teaching about lately?
I'm really the most excited about nurses leaning in and seeing their necessity for the success of this innovation, for this technology. If nurses don't come in and they don't lean in and they're not a part of it, we will fail round one. We'll fail round two.
Yeah.
So nurses, this is your call. This is your call to action. Don't wait until you think you know everything. You're never going to know everything. Say yes to that invitation. Say yes to that opportunity.
And don't even wait for
those
the
questions.
invitation. It sounds like
Find
ways in.
Find it.
The world
I encourage people nurses to find their voice. And when I teach this class around finding your voice, I say, well, where are you on the continuum? Maybe you're listening on LinkedIn and then I'm like, okay, could you like something? Could you occasionally comment? I know maybe you don't have the courage to, start a post and tag some of those big influential, the Rebecca Loves of the AI space, but lean in and take those chances. Find conversations that are interesting to you, that tap your passion. Start listening, start liking, start commenting. As a nurse, if you have, ideas and desires and want fulfillment in a different direction than where you are, start listening to those conversations on LinkedIn. Because when you start leaning in and commenting and listening and commenting, what'll happen is people will come to you. You'll attract the very thing you're looking for. They'll reach out to you and say, oh, hey, we actually are looking for this kind of position, this kind of role. And I again, when I moved into a clinical director, when I first moved into a chief product officer role, I was probably in the role about a year. And, and then my husband's like, well, do you think you can do it? Like, of course we can do it. We're nurses. We figure it all out. Yeah. So don't wait until you'll never feel completely confident or completely ready. Lean in, go for it. And again, I can assure you that your expertise will be so valued on these teams who don't have your expertise, but desperately want to build solutions that function in healthcare settings. And you will be seen as the linchpin from an idea to success.
Yeah.
And so I'm so excited for nurses.
I would like any nurse listening to this to go back to about somewhere around minute 3 to 5 when I asked about informatics and the change in the tone of your voice. You were excited to be here, and you were you, but something happened when you started talking about it. And I want you to go back and listen to that tone in her voice and start listening to that for that tone in yours. If you're confused about, well, I don't know, I've been, just going about my work, my business, and my passion's kind of fizzled out. I don't know what I'm passionate about anymore. Listen to Cheryl's voice when she started talking about informatics, and then listen for that same sound in your own voice when you start talking. And that's where your passion is. And it's beautiful how it comes through. I've never been so engaged in a conversation about data collection and informatics and the emergence of AI technology. Cheryl, this was wonderful. And I know it's just a 10,000 foot view. I know you have so much to teach. So everybody look for Cheryl Field on the RNegade platform. There will be this podcast, obviously, and we're going to be looking for more from you. So thank you so much for your time today. I look forward to the next conversation because it sounds like we haven't even scratched the surface.
Thanks. Thank you so much, Karen. Thank you for inviting me into your platform and for helping me to amplify my voice. That is, I'm very grateful to you for that.
Yeah, not just you're such a wealth. You're such a wealth. It's not only what's in your head about technology and informatics, but it's also that part of you about finding your voice, which is equally, if not more important. So thank you very much.
Renegades.